How does trauma affect the default mode network? How does trauma affect the default mode network? This question dives into the fascinating world of brain function and trauma recovery. The default mode network, often referred to as the DMN, consists of several interconnected brain regions. These areas are most active when we are not focused on the outside world, such as during rest, daydreaming, or self-reflection. Key regions of the DMN include the medial prefrontal cortex, posterior cingulate cortex, precuneus, and angular gyrus. This network plays a crucial role in self-referential thinking, memory, social cognition, and even imagining the future. When a person experiences trauma, especially repeated or severe trauma, it can disrupt the normal functioning of the DMN. Research indicates that exposure to trauma can lead to reduced connectivity within this network. This means that the communication between different parts of the DMN becomes weaker. Studies involving combat veterans have shown that both those with and without post-traumatic stress disorder experience decreased DMN connectivity compared to individuals who have never faced trauma. The most significant changes are often seen in connections involving the precuneus and medial prefrontal cortex. For individuals with post-traumatic stress disorder, or PTSD, these disruptions are typically more pronounced. Evidence suggests that the severity of PTSD symptoms correlates with the degree of reduced connectivity in the DMN. The network becomes less integrated, meaning its parts do not work together as effectively. Interestingly, certain areas within the DMN, particularly in the posterior regions like the precuneus and posterior cingulate cortex, may remain as more connected, while connections involving the prefrontal cortex tend to weaken. This pattern may contribute to cognitive and emotional symptoms associated with PTSD, such as difficulties with self-reflection, emotional regulation, and social interactions. Childhood trauma can have particularly lasting effects on the DMN, as this network is still developing during childhood and adolescence. Repeated trauma during these formative years may alter the maturation of the DMN, leading to long-term changes in how a person processes self-related and social information. From a clinical standpoint, these findings highlight that trauma impacts not just the brain's fear and stress systems, but also the networks involved in self-reflection and social relationships. This may help explain why individuals with PTSD often struggle with intrusive memories, negative self-perceptions, and challenges in social relationships. Changes in the DMN can be measured using brain imaging techniques like functional magnetic resonance imaging, and researchers are exploring whether these patterns could serve as biomarkers for diagnosing PTSD or tracking recovery. It is essential to recognize that while these changes are observable, recovery is still possible. The brain has an incredible ability to adapt and heal, especially with appropriate treatment and support. Professional mental health care, including therapies like trauma-focused cognitive behavioral therapy and medications when necessary, remains the standard for treating PTSD. Emerging research is also looking into whether interventions that target brain network connectivity could complement existing treatments, though these approaches are still under investigation. In summary, trauma can lead to measurable changes in the default mode network, particularly reduced connectivity that is often more severe in those with PTSD. These changes may underlie some cognitive and emotional difficulties experienced by trauma survivors. However, with the right care, many individuals can experience significant improvements in their symptoms and overall quality of life. Always consult a healthcare professional for personalized advice and treatment options.